All right, welcome to the Explainer. Now, if you're an anesthetist prepping for your exams, there are very few topics that are as critical or as high stakes as managing an obstructed airway. So in this Explainer, we're going to break down a masterclass based on the fantastic work of Lynch and Crawley to give you a really clear framework for success. Okay, so here's how we're going to tackle this. First, we'll get a real sense of the risks involved. Then, we'll build out a solid clinical framework for assessment. From there, we'll get into the holding measures that buy you time. We'll compare the big intubation techniques. And then, and this is a good one, we'll tackle the modern controversies in general anesthesia and the absolutely vital role of human factors when things start to go sideways. First up, understanding the risk. So why is this such a major focus, both in our day-to-day practice and especially in exam settings? Well, it's pretty simple. When that airway is compromised, the stakes aren't just incredibly high, and examiners want to see that you have a clear, structured way of thinking about it. So this number comes from the 4th National Audit Project, or NAP4, and it is a seriously startling statistic. 70% of major bad outcomes involved an obstructed airway. And what's even more worrying is that in a third of those cases, the management was considered poor. This is a key piece of data you absolutely want to have in your back pocket. So, here's the crucial point. Unlike other emergencies where you might have a nice, neat, universal algorithm to follow, airway obstruction just doesn't work that way. Experts disagree, and every situation is different. And what that means for you is that your exam answers and your real-world plans need to show a deep understanding of the principles, not just memorizing a checklist. Okay, so how do we actually apply all this in the real world? Let's build a solid framework for your assessment. This is exactly how you show clear, safe thinking when you're faced with an airway obstruction, whether it's real or in an exam scenario. This table is basically your diagnostic map. The very sounds the patient is making. Think about it. Snoring, gurgling, different kinds of stridor. They can point you right to where the problem is. So, for example, simple snoring might suggest an issue in the oropharynx, while an expiratory stridor, that points you down towards the trachea. Linking the sign to the site is a fundamental first step. This right here, this is your exam framework. Urgency, lesion, and safety. Seriously, burn this into your brain. Before you even think about reaching for a piece of kit, you have to systematically think through how stable is the patient, what exactly is the obstruction, and what's the environment I'm working in. This shows safe senior-level thinking. Okay, so what if the situation isn't a complete crash and burn emergency yet? That's where holding measures come in. They're absolutely invaluable because they buy you time to think, to plan, and to get your team together. Let's look at the main options. HFNC. You'll hear it described as revolutionizing airway management. And honestly, that's not an exaggeration. It's not just about pumping in oxygen. It gives you a little bit of positive pressure that helps splint the airway open, it cuts down the work of breathing, and it buys you precious, precious time. It's a total game changer, both for just holding things steady and for during an awake procedure. Think of these other measures as more tools for your toolkit. Now, the evidence for some of them, like steroids or nebulized epinephrine in adults, isn't super strong, but they are absolutely used to temporize a situation while you get more info and get your definitive plan locked down. So, which investigation do you pick? Well, it's all about balancing how much time you have versus what you need to know. Nasal endoscopy, it's fantastic because it's dynamic. You actually see the airway moving, breathing. A CT scan, on the other hand, gives you this beautiful, static, anatomical roadmap. The key is knowing what question you're trying to answer with the test. All right, let's talk about definitive management. When your patient absolutely, positively has to keep breathing on their own, awake techniques are your go-to. Let's compare the main players. AFOI, this is the classic, the gold standard skill, right? It's brilliant for navigating around big masses above the vocal cords. But, and this is a big but, it has some real dangers. It's super operator dependent, secretions can totally blind you, and in a really tight, narrow larynx, you risk what's called the cork in the bottle effect, where the tube itself blocks off the last bit of airway. A total disaster. And this is where awake videolaryngoscopy has just been a game changer. For a lot of us, it's a motor skill we're just more familiar with. And here's the key thing. The blade itself can physically move tissue out of the way to create space, which makes it incredibly useful for problems right at the larynx. Plus, that big screen gives the whole team a great view, which is huge for situational awareness. So the really crucial point here isn't about which one is better in general. It's about what's better for this patient with this problem. AFOI is great for stuff above the chords, AVL for stuff at the chords. You gotta match the tool to the job, and let's be honest, to your own skill set. But what if an awake technique is just off the table? Maybe your patient is agitated, they're hypoxic. Well, inducing general anesthesia is an option, but how you do it, that has become a huge point of debate. Okay, for decades, we were all taught the same thing, right? An inhalation induction, keep them breathing spontaneously, that was the safe choice. The thinking was, hey, it's reversible. But let's see what the data actually tells us. And honestly, the data from NAP4 is just damning. Inhalation inductions, they were a mess. Of 27 cases, only 4 went smoothly. We saw high rates of desaturation, lost airways. It wasn't pretty. The modern view, which is supported by tools like high flow and video laryngoscopy, is that a really well-planned IV induction with muscle relaxant might actually be the safer, more controlled way to go. This is a huge shift in thinking. Okay, finally. And please do not forget this part. No technical plan, no matter how brilliant, is complete without thinking about the human element and having a rock-solid final rescue plan. Just look at this data from NAP4. It's a huge wake-up call. Technical skill alone is not going to save the day. It found that human factors, we're talking bad communication, getting stuck on one idea, poor teamwork, contributed to a whopping 40% of bad outcomes. That tells you that your non-technical skills are every bit as important as your intubating skills. Your plan has to have a clear trigger, a line in the sand for this final rescue step. Everyone in the room needs to know what failure looks like and who is doing front-of-neck access. And in a true can't intubate, can't oxygenate nightmare, a formal tracheostomy, it's just too slow and complicated. The life-saving move is a surgical cricothyrotomy. It's faster because there are fewer steps and less dissection. And this right here is the ultimate takeaway. Your most important piece of kit might not be the scope in your hand. It's the team around you. It's the ability to communicate, to recognize when a plan is failing, and to change course decisively under crazy pressure. That is what makes an expert. So for those of you who want to go even deeper, and you really should for your exams, these are the core papers this whole explainer was built on. That Lynch and Crawley paper and the NAP4 report. Absolutely essential reading. Thanks so much for watching.